Hidradenitis suppurativa, or HS, is a chronic debilitating disorder that is frequently encountered in dermatology. Multimodal management is often required to address the medical, surgical, and psychosocial needs of patients affected by this complex disease.
That's Dr. Elisabeth Tracey on hidradenitis suppurativa. And this is Dermatology Weekly, the weekly podcast from MD-EDGE Dermatology. I'm MD-EDGE editor Elisabeth Meshkati.
And I'm MD-EDGE editor Terry Rudd. In today's resident takeover of the podcast, three dermatology residents, Dr. Elisabeth Tracey, Dr. Julie Croley, and Dr. Daniel Mazori, discuss how to talk with patients about hidradenitis suppurativa myths, tobacco use, and weight loss. They also provide strategies for managing flares, and they weigh medical versus surgical treatment of HS.
In the news, having atopic dermatitis may increase the risk of anaphylaxis in children with egg and milk allergies, and a survey highlights some of the issues dermatologists face when prescribing isotretinoin for transgender patients with acne.
You can reach Dermatology Weekly by emailing us at podcasts@mdedge.com. You'll also find that email address in the podcast description.
And now the news.
Children with atopic dermatitis and allergies to eggs and milk are at greater risk of anaphylactic reactions compared with allergic patients without atopic dermatitis. That's the primary finding from a retrospective review of data from nearly 350 pediatric patients, conducted by researchers from National Jewish Health in Denver. The research appears in the Annals of Allergy, Asthma, and Immunology. The researchers identified children aged 0 to 18 years with peanut, cow's milk, and or egg allergies, with or without atopic dermatitis. Overall, children with egg and milk allergies plus AD had significantly higher rates of anaphylaxis than allergic children without AD, 47% versus 11% for those with egg allergies, and 50% versus 19% for those with milk allergies. Anaphylaxis rates were similar in children with peanut allergies with or without AD, at rates of 27% versus 23%. The researchers say their findings suggest skin barrier dysfunction has a role in food allergy severity, and clinicians should counsel patients and families about the potential for more severe reactions to oral food challenges.
Dermatologists face a confusing process when prescribing isotretinoin for severe acne in transgender patients, particularly transgender men who were born female. That's according to a survey of 136 dermatologists conducted by Dr. Courtney Enslin of the Department of Dermatology at Johns Hopkins University in Baltimore. Dr. Enslin and her colleagues sent the survey to members of the Association of Professors of Dermatology, who were asked to distribute the survey to faculty members and residents. Some questions assess knowledge about the reproductive potential of transgender men and women. The survey also described clinical scenarios in which the physician needed to decide how to register a patient in iPLEDGE. Of the dermatologists who responded, about 12% said the complexities of prescribing isotretinoin to a transgender patient led them to choose alternative therapies. The survey also revealed gaps in their general knowledge about transgender patients and their reproductive potential. And nearly 90% of respondents favored changing the current gender-specific categories in iPLEDGE to gender-neutral ones, classifying patients only by whether they have the ability to become pregnant. The researchers say the survey results support ongoing efforts to reform iPLEDGE. They caution that current categories don't offer an inclusive approach to care for transgender patients. A recent AAD position statement on isotretinoin calls for a gender-neutral categorization model for iPLEDGE that's based on a patient's childbearing potential, not gender identity. The results of the survey were published in a research letter in the Journal of the American Academy of Dermatology. We'll be right back after this message.
And now, Dr. Elisabeth Tracey, Dr. Judy Croley, and Dr. Daniel Mazori.
Hidradenitis suppurativa, or HS, is a chronic debilitating disorder that is frequently encountered in dermatology. Multimodal management is often required to address the medical, surgical, and psychosocial needs of patients affected by this complex disease. My name is Elisabeth Tracey, and I'm a dermatology resident at the Cleveland Clinic. I'm here with my fellow Cutis resident corner columnists to talk about strategies for the comprehensive treatment of HS patients. First, I will have my colleagues introduce themselves.
Hi, my name is Julie Croley, and I'm a dermatology resident from the University of Texas Medical Branch in Galveston, Texas.
I'm Dan Mazori. I'm a dermatology resident at SUNY Downstate in Brooklyn.
Thank you for being here with me. HS is a chronic inflammatory disorder of the pilosebaceous unit characterized by recurrent painful nodules in the body folds that can drain, scar, form sinus tracts. One common myth among patients is that HS is an infectious disease. Have you encountered this or other myths about HS?
I've had patients ask me similarly if HS was infectious or contagious, especially patients who are teenagers. They've asked me specifically if it's a sexually transmitted disease because it can affect the groin. So that's a common myth that I've seen in our peds derm clinic.
I've had patients who subscribe to the myth that HS is caused by poor hygiene as well. I think this often stems from misinterpretation of the fact that HS is multifactorial and may implicate skin flora in part of the pathogenesis. I think this really highlights the importance of patient education.
Yeah, with the poor hygiene myth, I think that I've also had patients along those lines ask if deodorant is safe because they're not sure if somehow that's contributing to their hygiene in a good or bad way. And I never knew that was something that was a myth until a patient asked me that concern, and I wasn't sure. So I looked it up, and there's actually a study that was published in the 80s in the Archives of Dermatology where they looked at deodorant use in HS patients and controls, and they found no significant difference between the two populations. So that's something that we have data to be able to reassure our patients that that's not something they need to worry about.
The correlation with smoking status has been documented, though. How do you talk to patients about that?
I like to open with stating the non-accusatory fact that tobacco use has been correlated with HS, and that I recommend for all of my HS patients that they either maintain abstinence from smoking or stop smoking if they currently do. I like to follow this by asking about the patient's personal smoking status. I find this strategy useful in making the patients feel comfortable about talking about this topic.
Yeah, I think that's a really great strategy and approach by starting with the facts before asking the patient specifically about their habits. I think that's a really nice way of not coming across as judgmental. So I think that's an awesome technique.
I think it's also to sometimes ask the question multiple different ways because sometimes patients only associate smoking with smoking cigarettes, and tobacco is now used in multiple different ways. And I think it's important to make sure that we understand whether or not they're using tobacco in any way, not just smoking cigarettes.
Definitely. And I've had some patients who have a hard time believing the relationship between their smoking and HS just because in some cases they've been smoking for a really long time and the HS is a more recent condition. In those cases, I try to mention the evidence about how smoking can decrease the efficacy of treatment. And in those patients, I found that that's another way to get them on board with smoking cessation if they're not otherwise noticing the connection between smoking and HS in the first place.
That's a good point.
Exactly. I like to tell patients that tobacco use is seen in the vast majority of HS patients. 70 to 75% of patients are active smokers. And similarly, with the issue of weight loss, about 75% of HS patients are overweight or obese. So how do you talk to your patients about weight loss?
I like to approach this question in the exact same way as I do for smoking, with stating the fact that HS is related to obesity and being overweight. And then I like to redirect to more patient-related questions and recommendations. I find that this makes the conversation more comfortable and the patient more willing to talk about the issues.
I think weight loss for me has been a harder subject to talk about than smoking, just because for whatever reason I feel like patients, as hard as it is to quit smoking, are able to get on board with that. But with weight loss, despite different strategies like referring to different specialists, I think that's just something that my patients have struggled with trying to improve on more. So I don't know what the best way to go about that is, but it's definitely something that I don't think is easy to do. And I think it's hard for patients. It's hard for most people to lose weight. So that's something that I've noticed in our clinics.
In my experience, when I've brought up referrals to nutritionist counseling, my patients have been very receptive to that. I think that's one way to approach the topic. And I haven't been able to see these patients in long-term follow-up yet, but they've been very receptive to the suggestion.
Similarly, I like to approach the topic, too, from a standpoint of diet and exercise. You're giving them strategies, I guess, for the overall goal of weight loss. Weight loss is a very difficult goal for most people. And if you talk about it in terms of diet and exercise, it tends to give people tools and strategies to achieve that goal. So I think it kind of breaks it down into easier pieces for people to digest, and just, overall summarizing that the strategies are diet and exercise, but the overall goal is weight loss.
Yeah, I agree with you guys. And I think part of it, too, also depends on, where the patient is and their disease status. So, if they're acutely flaring or if they're really severe, to the point where they can't move and their mental health is really impaired, maybe talking about weight loss and smoking in those moments isn't the right time. But, if we're able to get them to a better place with medical and surgical management, to a place where they can even wrap their heads around weight loss, smoking, these sort of more lifestyle changes that can be harder to achieve, I think that's another thing to think about, is kind of the right time to bring up these different lifestyle changes.
So we know that hidradenitis is complex and that the optimal regimen for patients is equally complex, and patients require long-term background treatment to stabilize the chronic aspect of the disease, but then they also need treatment for flares. How do you plan ahead for managing these flares?
So we tell all of our HS patients to anticipate flares. I think part of it is giving them the anticipatory guidance that flares may happen, probably will happen. And we tell them that they can walk into our clinics without a scheduled appointment if they're flaring. And we have that kind of walk-in policy for all of our HS patients. Something that we don't do at my residency, but I've heard other dermatologists doing, is prescribing patients short courses of either oral antibiotics or oral steroids for them to have on hand in the event of a flare.
We use some of the same strategies you just mentioned, Dan. We do let patients walk into the clinic without a scheduled appointment if they're flaring. We put a little blurb in our clinic notes telling our nurses that, hey, if this patient calls, they can be worked into the clinic without having a scheduled appointment. In addition to that, I like scheduling these patients for close follow-up. The disease can be very distressing and stigmatizing to patients, so I like to have a sort of built-in system for patients to be able to access me easily. I typically do 3-month follow-ups for patients, even if they're doing well, just to kind of check in, see how they're doing, see how their progress is. Sometimes they need me, sometimes they need me a little bit less. But I think it's just an overall good strategy to have that in place.
Julie, I agree. I think close follow-up is really important. In the beginning, when I'm getting to know a patient, sometimes I'll see them as often as every 4 to 6 weeks, to make sure that they're adhering to everything and adjusting, making changes. So I think that the idea of close follow-up is critical. So I agree with that for sure.
Mm-hmm. Yeah. Dan and Julie, what surgical treatments do you recommend for your HS patients?
I view surgical treatment as an option for severe or refractory disease. Primarily, our institution has a really good relationship with our plastic surgery department. Our plastic surgery department is very good at the surgical management of HS, so I often refer these patients for evaluation without much reservation. I think it's important to have a relationship with a surgeon that has a lot of experience and is able to appropriately triage patients for either surgical management versus continued medical management. And I think having faith in this type of surgeon is an important relationship to have in the management of HS patients.
Yeah, I think the role of surgery is really interesting because I've worked with some attendings who think HS is primarily a medically managed disease and surgery is adjunctive, and then attendings who think the complete opposite, that it's primarily a surgical disease and medical management is the adjunctive therapy. So it's been interesting to train with attendings of both mindsets. But for the most part, like Julie mentioned, we discuss the option of surgical excision for more severe disease. It's usually for axillary disease where we talk about excision. For more surgery in the acute setting, we also offer our patients deroofing with a punch tool where we deroof an individual lesion, scrub the resulting cavity, and then let the defect heal by secondary intention.
That's interesting, Dan. I think at our institution we do a lot less surgical management for HS patients, and maybe that is because our plastic surgery department has such an interest in surgical management of HS patients, but really my surgical experiences with HS are limited to intralesional Kenalog injections. I think it's just something that's less popular within our department. I think that attests to like.
Oh, sorry.
Sorry. I was just saying I think that attests to, Dan, to you were saying, there are people of the mindset that HS is more of a medically managed disease state, whereas others are of the mindset that it's more of a surgically managed disease state. And I think that is, one attestation of that.
Yeah, and I think a lot of it also ends up depending on the individual patient. So if we have a patient who's pretty mild and not improving with intralesional triamcinolone, then that's a patient where maybe the pendulum swings more towards doing punch deroofing. But I would agree, Julie, that for the vast majority of our surgical procedures, we are doing intralesional triamcinolone over deroofing with a punch tool. A surgical procedure that we try to avoid at my residency program is incision and drainage. For patients who have acute lesions that are very painful, we tend to treat those with intralesional triamcinolone instead of IND. In our experience, we found that intralesional steroids gives patients a better outcome.
That's a general feeling at our department as well. We do intralesional Kenalog quite often for patients with HS and generally steer clear of IND.
I agree as well. IND can provide some pain relief, but so can intralesional steroids. There was one study that showed that intralesional steroids provided patients with a notable decrease in pain, size, and drainage of acute lesions after just one day. So I think that's preferable to a surgical procedure that will lead to recurrence, as INDs almost always do. What lasers do you use for your HS patients?
For patients who have mild disease, we recommend laser hair removal using the same lasers that we recommend for hair removal anywhere on their body based on their skin type. And the whole idea with that is that we're targeting the pilosebaceous unit that is believed to be at the crux of the disease.
We use lasers in HS patients in the same capacity. In our department, we typically use lasers for hair removal for patients with mild to moderate disease. typically Nd:YAG, Cutera. Those are the lasers we have available at our department that we use.
Nd:YAG laser treatment is supported by randomized controlled trial evidence and can be used to treat an entire affected area to, as Dan said, treat the pilosebaceous unit, and then it can also treat active nodules if you use stacked double pulses. And the long pulse alexandrite and diode lasers and intense pulse light can also lead to follicular destruction. Not as much evidence there, but those can also be recommended.
Yeah, I don't have a lot of experience with the other laser therapies, but I have read about them. It'd be interesting to see their use at our institution.
Have you guys had any success getting these laser treatments covered by insurance for your patients, or are they usually paying out of pocket as if they would be for a cosmetic procedure?
The patients I have with HS that I'm treating with laser hair reduction are paying out of pocket. I think our department has a very generous cosmetic package. It's not terribly expensive for patients when compared to private practice, but they still are paying out of pocket. I haven't tried very hard to get these covered by insurance companies, so I'm not sure if it's something that they would cover easily. I don't know, do y'all guys have experience with that?
I personally don't have any experience with that, no.
I don't have any experience getting lasers covered, and the only thing I can think of, I had one of my co-residents get botulinum toxin covered for hyperhidrosis in the setting of HS. So,
interesting.
So that was interesting, yeah. We also have discounted resident cosmetic laser clinics, so we have that available to our patients.
We have the same thing at our institution. We do resident laser therapy is half the cost of faculty laser therapy. All of our faculty sign off on our laser settings, so it's kind of a good deal for the patients because they have the eyes of a faculty kind of looking over the settings, and the residents are the ones actually doing the procedure. And then our cosmetic packages come in small, medium, and large sizes. So depending on the area that they need treated, we charge based off of that. So for a small area, like if you were just doing the inguinal area of an HS patient, we typically charge that as a small treatment size. And if you're doing resident pricing, it can be pretty affordable to the patient. But larger areas, of course, would be more costly.
Yeah, so I think that's important for anyone listening with an HS patient who may, not be able to afford laser treatment otherwise and aren't able to get it covered by their insurance, to look out for cosmetic clinics that are affiliated with a residency program, because I think in general those tend to make it more accessible.
Thank you for sharing your experiences on treating this complicated condition. And this brings us to the end of our discussion. I hope that we helped to illuminate some useful strategies for caring for patients with hidradenitis suppurativa. I am Libby Tracey, and on behalf of my fellow Resident Corner columnists, thank you for listening. This has been Resident Takeover.
And that concludes this week's episode of Dermatology Weekly. To get past and future episodes of Dermatology Weekly, subscribe now on Apple Podcasts, Google Podcasts, or wherever you get your podcasts. I'm Terry Rudd.
For Dr. DeLeo, MD-Edge editor Melissa Sears, and all of us here at MD-Edge, I'm Elisabeth Mishkati. Thanks for listening.